I'm a dental technician, Jaedoo, who thinks with his hands. I run the Welcome Laboratory in Busan. Nice to meet you. Today's lecture is about the full arch system of DO-Navi. First, you need to know the overall workflow. Today's lecture will cover 3 parts. I will first tell you about the theoretical aspects of the full arch system. And then I will tell you about the case we have recently been working on. Lastly, I will tell you in more detail about the tips and procedures for immediate prosthesis seating. First of all, I will give you the definition of DO-Navi full arch system, or so-called all-on-4, all-on-5, and all-on-6. Usually, all-on-4, 5, and 6 refers to the number of implants that will be placed. 4, 5, 6 refers to the number of implants that is placed. We call this type as a hybrid prosthesis. Hybrid prosthesis is a product that is made by compounding the advantages of various materials. A screw-retained bar goes in the hybrid type, and a denture-like prosthesis goes on top. We call this all-on-4, or, because it is a prosthesis made with DO-Navi process, we call this the full arch system in DO. Let me tell you about it in greater detail. DO-Navi full arch system is largely divided into 2 types. When the patient first visits, if there is a denture that can acquire the patient's VD, you can move directly onto step 2. But if there isn't one, we use a wax denture to acquire the VD. Using a wax denture, we can soften the wax by immersing it in slightly hot water. Through the relining in the inner surface, we can register the entire inner surface and the occlusal VD. This will be step 1. After VD is acquired, the following will be step 2. In step 2, you need to scan the inner and outer surfaces of the denture. You need to scan the antagonist and the bite. The data is then sent over to the guide team, and a surgical guide is created. Provisional bridge prosthesis will also be made, and both the guide and prosthesis will be sent to the clinic. The prosthesis will be loaded immediately after the surgery, and the final prosthesis will be inserted based on the data of the immediate prosthesis that was scanned on the 4th visit. This highly simplified system is the full arch system. The advantage is that the patient would not have too much difficulty because the VD, once captured, can be used over and over again. With constant change of the VD, not only is it difficult for the patient to adapt to it, but it may also cause some inconveniences. The advantage is that we get to keep the VD that the patient is used to, and that the work can be done within a minimum number of visits. In fact, I am concerned about controversies over the system that may occur if I talk about the strengths, reasons for use, and weaknesses of the full arch system. Those are not for me to talk about, so I would like to leave them to other professors and other experts. Today, I will tell you more about the immediate prosthesis. Let's take one more look at the overall system. With the consent of the patient on the first day, we perform an oral scan for surgery. You can also scan using the maxilla and mandible dentures. You need to come up with something that would get you the VD. So whether with a wax denture or an old denture or a wax rim produced inside the patient's mouth, you should get the patient's VD. And the file is sent over to the guide team in DIO, who will design the guide. The design on which the immediate prosthesis is placed is performed with the final data from the guide design file. It is printed in PR. These various ways you see above are used for post-surgery settings. On the third visit, the patient undergoes a surgery like this. Using the guide, the immediate prosthesis is placed after the surgery. The immediate prosthesis is rescanned, and based on the scanned data, the final prosthesis is designed. And you can understand the final setting as the one made from the two-piece final prosthesis. As I said before, the overall VD may require some adjustments if it is not the first VD, but the final prosthesis does not require much adjustment because it uses the VD where the bite was made in the PR status with the immediate prosthetics inserted. I have seen a lot of cases, but considering that it is a full mouth case, the adjustment to be made is very small. The system inside includes these things. There are abutments for multi-unit. In the past, CCM or other things were needed, but now, not all these are needed. So let me just mention a few things that are needed. Among the many contents in the catalog, this is the most important. There is a multi-unit abutment of a straight type and a multi-unit abutment of an angled type. And for analog acquisition, there is a range of types such as pickup impression coping and transfer impression coping. There are also scan bodies and scan adapters. But you wouldn't need these if the immediate prosthesis has been loaded. That's what I want to talk about today. The CCM, or cylinder in the back part, are used in analog method. When we use it, you can think of the temporary cylinder as a standard. This is the digital lab analog. On the top, this is the lab analog that uses an analog method. The bottom is the digital lab analog. When you print and use, you can understand it as the model being mounted here. And here is a screwdriver. The content is similar on the back. You can think of it as the process for taking an impression for a pickup impression coping. Overall, in the lower part, there are scan bodies or adapter for digital, and lab analog and digital lab analog for analog. What I said earlier, I was talking about theoretical aspects in general. I was talking about the general composition. From now on, I will look at each of them and tell you about what actually is there and make a comparison. Basically, you can think of this as the post-process on the first day of surgery. You need these pieces of equipment or materials. This printed model you see below will come printed like this. One half is printed and the other half is not. The one half is when the gum formation is done, and the other is without the gum. I'm going to do the same with this case today. This is same as the situations in the actual oral cavity. Everything I said before is covered in the same way here. If you look at this part, the temporary cylinder is used to combine the printed immediate prosthesis with the multi-unit abutment. If you see here, this long object is the temporary cylinder, and the multi-unit abutment is an abutment that connects the fixture and the upper prosthesis, and there are two types. First, the straight type is a type that is standing straight. And for the angled type, there are two types, 20 degrees and 30 degrees. Let me go back and say this again. The important thing is that you need to know the abutment in the first place. You can understand it as a holder of an abutment with the actual abutment underneath. I will tell you once again about it with the photo later. The straight type has a white holder like this, and underneath is the abutment. There are a total of 4 cuffs, ranging from 1.5 to 4.5. The diameter is the same, 4.8 pi. The above multi-straight abutment is of a non-hex type. The angle type is a hex type. Because the angle is fixed, you use that angle to match the angle. It is said that the angle of one abutment is about 30 degrees. It is said that, with full mouth as a standard, it covers a span of 22 degrees or less. Then, the case that is not straight should be worked with the angled abutment like this. There are 20 degrees and 30 degrees. The angled abutment also comes in 4 types of cuffs. The angled abutment is disadvantageous in that it is a little more difficult when setting it because the angle of the angled abutment lies on one side with the screw pin inserted in the rear. I'll show it again later. But since the angles of the anterior and posterior teeth have to be different, the implant fixture has to be fixed that way. So for the anterior teeth, many cases require use of angle. Considering the entire path, the DO Navi production team will select the right abutment. I'll move on and mention it once again. As you can see, the straight type has a white holder like this. The reason that there is a white holder is that it is not easy to fasten in the mouth. Specifically, because it is a non-hex type, it will be difficult to hold, and it will almost be buried in the gums, or it will be as flat as the margin. That's why there's a holder on top for you to use. You can remove the white holder later, and there is a driver for it. There is a screwdriver for the full arch, and you will need to tighten it with this screwdriver at 30 Newton. And this is the lab analog and the upper holder later. When you use this holder to connect the temporary cylinder here and the prosthesis, when you work with resin, you will use this holder. In the meantime, the rubber dam prevents it from flowing into the fixture side. After that, since these screwdrivers are very small, you will have to take care when storing them. For resin, you can use direct resin or other different types of resins. And this is a curing machine. You need these settings prepared for one prosthesis. I will talk to you about it using a case example. Denture was originally used for the maxilla of this patient. RPD was used for the mandible of this patient. We plan to place 3 fixtures at a time in the mandible. We plan for all on 6 by implanting 6 fixtures in the maxilla. It was the denture actually used by the patient. Fortunately, because there was a denture, VD was not a problem. In the case of this patient, another method was used, which was to use this denture itself when scanning the inner and outer surfaces. The reason was that I thought it would turn out worse if I excavated the inner surface of the denture. So a printed duplicated denture like this was produced. The reason I used this denture, that I duplicated the denture in this way, was to put something like blue resin inside to merge all the CT files so that the guide team can use the files at once for design. The maxilla and mandible scans have been completed. On the inner surface, a light body was used to record the inner surface. I put blue resin on the inner surface to capture a full mouth point on the CT. These are the reverse data. These 4 protrusions are where the blue resin was placed. So CT and the vertically flipped data were attached at once. We did it all at once. It was designed by the guide team. The anchor was also included, and we designed it to place a total of 6 fixtures like this. This is the guide design file. The surgical report came out like this. After receiving everything, we were told that we could use 4803 4.8 pi cuff 3 of the straight type. So we made suitable preparations. We got the guide file. Of course, we used the guide file to design the immediate prosthesis. As it was not easy to put the anchor in place in a case like this, I did a model printing once. So, you may put a guide here and fix it with something like a putty on the inside. But we didn't have to do that in this patient's case because the guide had already touched the antagonist and the anchor was implanted, as is for surgery. I designed the immediate prosthesis like this from the same file. The direction of the hole was made based on the guide, and it was drilled to sufficiently wide sizes. This is the front surface that was printed. I printed with Probo from Dio. The printing speed was fast, so I was able to print them all in 30 minutes. One downside was that we had to add a lot of sprues, so the bite changes little by little. It's good to adjust the bites little by little to make them similar overall. Honestly, I always feel that fewer number of sprues would be better. So it would be better to try to reduce the number a little more. This is the printed model. What you need to see here is that the part you see is open as a whole. It wasn't completely blocked. With the rugae as the border, I'm thinking that I will fix with the rugae and put the resin as a whole. It is now set in the mouth. The fixture was well placed. There was little adjustment to be made when I placed the immediate prosthesis that I just made. The doctor took a lot of care during surgery, and it was a good fit. So I only added a few finishing touches on the inner surface. So on top of the fixture in the middle that you see here, there are straight and 6 of 4.8 pi cuff 3 that I mentioned earlier. When you fasten it, first place it with a holder. Then, tighten it at about 30 Newton using a screwdriver. After tightening, place the prosthesis. What you need to do first is to put a rubber dam on that point. The reason for inserting the rubber dam is to prevent the unlikely risk of resin flowing into beneath the undercut. You can understand the role of a rubber dam as preventing the resin from flowing in. So I laid the rubber dam as a whole. And when fitting the prosthesis on it, I set it with the hole as a standard. There is a temporary cylinder in the middle. The temporary cylinder, which I will talk about later in practice, has its own length. So it would be better to cut it in advance. So we place the resin as a whole like this and squeeze it in. When you squeeze the resin, you don't have to fill it in too high. You only need to squeeze until it is hardened enough. After curing, if the entire curing is over, you can unscrew it and remove it like this. Most of them will fall out with rubber dams that we inserted previously on them. If you look closely at these parts here, the parts where the rubber dam was inserted will have a gap between the abutment and the immediate prosthesis. I will remove the rubber dam from that part and put the resin back in later. This holder is what I will use then. The lab analog should be inserted because it prevents flowing in to the inside. So insert the lab analog and fasten the holder on top like this. When fastening the holder, the resin will not have hardened completely. There is no guarantee that it will cover a sufficiently large area, so be sure to hold the lab analog like this. On it, tighten the holder. We do it like this when we make a pickup-type implant case. And if you don't hold the bottom and turn the holder on the top, it will spin if curing is not complete. Then, you have to do it again from the top. You have to take it all out and do it again. So, you should hold the lab analog firmly when working. Like I said before, add sufficient amount of resin to fill the inner surface. Use an explorer to push in some that are not filled. Perform curing. As you can see on the left, perform on the outer surface as well. If you see here, the holder size varies. There is a small one. If you see here, there is one that fits perfectly. I'll show you later, but if the holder size is small, you have to excavate as much of the inner surface as the screw size, so check the size once. There is one that fits the holder size. Use that. When you fill the entire resin in like this, there wouldn't be too much to adjust later. You will only need to polish overall. As you can see on the right, perform curing in this way. After a few practice, I realized that it was much faster for 2 or more people to work on it than doing the work alone, especially when adding resin. The amount is too much to work alone. It is much better to have 2 people sitting next to each other and curing parts that are not visible to each other. After finishing all of these processes, cut off the wing on the back here. That's why, as I told you before, I made adjustments in advance to cut it easily. Of course, there will be no problem working without it, but the position of the ruge on the border side changes little by little because it can't be held on the hard part. Since this is a way to fix the position in place using the wing like this, use this wing and cut it in the end. If the resin is completely filled, trim it like this. The inner surface is filled and cut out. It looks like both the wing and the inner surface are all filled. I recommend inserting the screw once. If the screw does not go in, check it once after it is trimmed on the outside from the inside of the mouth. You can put it as is into the mouth. When setting it, place the screw in a container on the side or in a clearly visible place. Because the screw is very small, and because it is not compatible with other screws, if you lose it, you will be in trouble. So put the screw on the side in a clearly visible place. From my experience, it takes much time to insert the screws one by one into the screwdrivers, so prepare a couple of screwdrivers in advance. It would be better if one person puts a screw into a screwdriver and passes it over, and another person keeps tightening the setting with the screwdriver. It is also difficult to find them one by one. And as technicians continue to work, they sometimes fail to pay attention and miss the screw. Finally, the prosthesis is inserted like this. As I said, the posterior is in RPD now. Since the implant was originally planned, the posterior bite does not really matter. I only captured the premolar, but it doesn't end here. A more important process remains from here on. In my opinion, the confirmation process is more important. If you look at the X-ray, you must check on the X-ray whether the abutment of all fixtures and the temporary cylinder are completely connected. Whether you're using a panorama like this or a standard apical photo, you'll need to take photos to confirm. And there are some gaps. It's inevitable. Since this is a one-piece prosthesis, it is a little difficult to fit perfectly. However, since it is touching the base, no problem is found, even in the one-screw test. Anyway, you should make sure that it is completely tightened like this. This is a mistake I made before, actually. If you see here, there is a picture with a gap like this. The reason is that when the temporary cylinder was removed, the resin was not hardened, so the multi-unit abutment inside was also unwound. Once I continued on the work in that state without realizing it, and ended up with an unfit mandible frame. So please make sure to check that part. If it is sometimes difficult for you to see it, or the angle makes it difficult for you to see it, I recommend inserting a screwdriver, like to take an apical photo. The one on the right is hex, because it is an angled type. So you should also check if the hex surface is completely attached to the thread on the hex side. These on the left here are non-hex type, so you just need to turn to fasten it. But the hex type will definitely not fit if the hex angles differ. Check on the panorama or standard to see if it is securely fastened. Then, if there was no problem with the overall position in terms of the bite, and there was no problem with the overall tightening, fill the inner surface once for the final prosthesis. Of course, fill when there is an empty space in the inner surface. This patient had a few voids in these areas. In fact, in some cases, it goes down a little more after the surgery, so use something like a light body to record the base again. There are two ways. One way is to just scan the inner and outer surface and scanning it once more. Another way is to complete the base surface and scan it once. At this point, when recording is complete, you can scan the immediate prosthesis. Now you need to scan the inner and outer surfaces. One thing to note when scanning the inner and outer surfaces is that the inner surface of the temporary cylinder should come out perfectly. The most important thing here is to reverse it using the temporary cylinder. So if this part does not come out properly, further work is impossible. So you have to scan this part clearly. Scanning on the outer side will not be easy. If it doesn't scan well when holding it in your hand because it shakes, you can do it as I showed you. As I showed you earlier, everything is set. But if you see here, there will be things such as magic lines. When using a general scanning method, during scanning, it might not scan well, or it might not scan at all, because the data may be considered as being same or similar. So it's a good idea to use a marker to give landmarks. And you can delete it later. And sometimes the midline can be changed. Because it is an immediate prosthesis, we cannot have the perfect length. One way is to adjust the immediate prosthesis itself and send it over. If that doesn't work, it would be much better to use a marker pen or other means to tell which part to delete. Since it is difficult to scan the inner surface as well, you can draw a line here. It is important to scan the inner and outer surfaces of the immediate prosthesis. Since this case was of a maxilla, the mandible was scanned in the intraoral status. For the maxilla, take out the immediate prosthesis and scan the bite while tightened and send over the data. Then, we use the inner surface to reverse the data. Then, we design for the final prosthesis. The purple part here is the immediate prosthesis that is all set. There will be such requests as please lift the rear side or please adjust the length like this. Considering such, I use this as a pre-prep for design. This is how it is designed. So because I am going to put pink resin on this part of the base, I cut back like this. I make the teeth separately. Overall, as I refer to it as a hybrid type, the immediate prosthesis using DL Navi is largely divided into two. The bottom would contain a metal frame. Think of it as a metal frame cut back 1.5 millimeters to 2 millimeters from what we've designed. And zirconia comes out separately at the top. So, the final prosthesis is a cementation of the two attached together. There may be a prosthesis using PMMA for the upper prosthesis, or there may be a prosthesis with zirconia. The base is metal, and the border between the two is processed with pink resin. This is the final result of the surface. Since it is one piece, the base surface is very important. Here, check for any tilting by conducting a one-screw test. Insert a screw one by one to make sure everything is fastened and there is no tilting. We used zirconia in this case. This is what it looks like when seen from the occlusal surface. As for the base, as I mentioned, these parts are all processed with metal. Sufficient pressure is applied with metal as well. Excessive pressure, however, is not good, so the other surfaces are open in a round manner. This is the final panoramic photo. As you can see, all surfaces fit well. Actually, I was there when it was all set, and the adjustment took less than 10 minutes. There was very little adjustment. The maxilla was set like this. The overall height of the mandible was set using the maxillary PMMA on top, and surgery had already been performed on the mandible. Accordingly, the prosthesis using the full arch system on the maxilla was completed in 3 visits for this patient. This is a picture of the occlusal surface. The overall workflow proceeds like this. From now on, I will use the training aids I prepared to show you how to set up the immediate prosthesis that was in the first half, not the one in the second half. This was made with the probo you saw previously. It's an immediate prosthesis, and you will see a few sprues here. After cutting out the sprues, the bite inevitably changes a little, like I said. So please understand this part, as it is unavoidable. I trimmed it, and this was the result. We processed one half in pink. If I were to use training aids to do all 6 of them, it would take too much time, so I'm going to put in only 1 or 2. One has already been put. I will briefly cover what goes in from this stage. It's the printing model I mentioned used to capture the VD in the first place. At that point, you need these sticks that can serve as stoppers front and back. However, since it is already touching, when I put the guide here in this case, it doesn't really matter. Let's suppose this is an intraoral status. I will put this in this status today. If you see here, this is the digital lab analog. You can think of its status as a fixture status. I will also explain the process of connecting the multi-unit abutment on top. There are several materials. Among the materials, first, the most important one is this abutment. As I said, the abutment has 2 major types. This is the angled abutment. This is the straight abutment. Since this case only requires the straight abutment, I used straight here. As you can see, we have a holder. We have a white holder on the top and abutment on the bottom. In the oral status, if the fixture of the patient has been placed like this, insert it and turn it clockwise. You can use your hand to turn it. If you take it out at that state, it will be placed in this position. There is a driver for it. Align the hex with the upper part of the driver and tighten the torque, setting it at 30 Newton. That's how we connect the abutment. Let me show you one more case. This can be used like this in a straight type. This one is called MAA 482520. It means that it is of 20 degrees with a 2.5 cuff of 4.8 pi. MAA means multi-angled abutment. MSA here means multi-straight abutment. There is a difference between these two. The angled abutment has a slightly different shape. The previous one had a holder, but this one does not have a holder. It has a jig. Indeed, it has a metal holder. But this holder of the angles is in the direction of the screw, so the holder faces a different direction. The screw faces this direction like this. The holder protrudes like this. The reason is that it requires changing the angle. Even if you look from the side, the angle is different. So it is almost impossible to tighten the screw while holding it in the mouth. Since it is the hex, you hold the angle like this. Hold this holder and tighten the screw. If you feel that you have tightened it to a certain extent, unscrew the holder and tighten the screw again to confirm once more that the tightening process is complete. So that's why this holder is made of metal. This is what gets you confused with this holder. I will tell you once more when fastening, but this holder is thin, because it has to be inserted here. And the one that actually is inserted to the cylinder is much thicker. So this will have a gap, and you have to use thick ones, not this one. The straight type looks like this, and it would help to know that you should hold the holder on top to tighten the screw like this. If you connect the straight type with multi-unit abutment as we did before, the metal cylinder should be mounted on top. This is a temporary cylinder, but there is only one type of temporary cylinder in market. It's quite high. So as you can see, it is generally better to cut it before surgery, except for cases with significantly VDs. When you cut it, you will see lines here. It would be better to cut 2 millimeters above the last line of these lines. Because if it becomes too short, the screw may be exposed in the future. You can cut it out a bit in advance and sideways from the last line and slightly upward from the diagonal line. And it doesn't matter if it's low when it actually gets inserted. because it gets buried in resin anyway. You can think of this as something that holds the place in the middle. If a long one inserted like this is exposed like this, it is almost impossible to cut this temporary cylinder inside the mouth. And you can't check the bite at all. So, if you prepare a short temporary cylinders in advance, it will not pose a big problem because the slightly short length can be filled with resin later on. So if you are going to do 6, it is better to cut all 6 in advance. You keep the length in mind when you cut it. It is the holder that goes on top of this. As I mentioned earlier, there are 2 types of holders, and there are 2 temporary cylinders, as you see here. I'll show you here. One is a thick one whose size fits perfectly. The other, you can think of it as the same holder that was used in angled just before. There is a lot of space left here. The space here is full. This screw won't be released later. Then, you would have to use a round burr to excavate later on. To do away with all that annoyance, work with something normal that's thick enough. Of course, this process is impossible to carry out inside the mouth because it is too long. In the mouth, you will have to do it with a screw inside. This is to prepare you for a case where you have to fasten the lab analog like this. In fact, you should first check whether the height of this abutment that was previously inserted after surgery in the mouth is even. And if the height is even, insert the temporary cylinder that was cut in advance. And then tighten the screw. Since it is non-hex, there is no separate angle. I mentioned that the first lower fixture and MUA are 30 Newton. But now, for the upper part, you should tighten at about 20 Newton. I think I tightened it with a torque of 20 Newton. It doesn't really matter right now. Let's assume that the front has also been tightened at about 20 Newton. The first thing you need to do is, after overall alignment, you should make sure that the size of this temporary cylinder fits. If the hole is small, you will have to check the hole and excavate a little more. We can't guarantee that the surgery will result in the same way that we thought and designed. Therefore, it needs adjustments here and there. If you think that there is no problem overall, with nothing getting stuck, now it's time for you to insert the rubber dam that was cut beforehand. You don't have to drill the hole to an overly large size. As you drill down, there is one raised spot that gets stuck like this. There is a raised spot beneath the temporary cylinder. The rubber dam will get stuck on this spot. It would do even if it doesn't reach the spot when it gets stuck. You can leave it as is because you will eventually have to fill the bottom part once more later. Then, you can layer or cut off the rubber dam. If the position is too high, there would be no room for the resin to hold later. So, it is best to lower it as much as possible. Even if it ends up like this between the two, it shouldn't be a big problem. Later, even if this part really becomes void, we can put the impression material in the inner surface, so it doesn't matter. When the rubber dam is inserted, check that it is completely placed on the inside of the space, and then hold the prosthesis here. And you can hold the wing like this too. You can make a larger wing and press this part to make it. Now that I'm going to use the training aids, gaps are unlikely to occur when I do this. Because it is made using the denture that we made to acquire the VD, it's almost similar. Hold it like this. If it is inserted like this inside the mouth, hold it like this with one hand and fill the resin with the other. As I mentioned at this point, it's better to work with more than one person. When working, do not insert to the occlusal hole first, because the hole is blocked if you insert to the hole first, and you cannot remove it later. So fill in the void area in its entirety around the hole and on the side. If you feel that you have filled it up to a certain extent, you can use the Explorer to stack it in. And in fact, there's no need to fill it in entirely. Resin does not matter too much, because the resin colors at this point does not surface as they are later on anyway, and the resin is just used for blocking. It's not very important. The important thing is to make sure that the resin is enclosed all the way around, with the hole not blocked. Use a mirror or the like to check it once more. If there is a void, fill it up a little more. You can fill it in like this. You can fill the rest in the same way like this. Then, if curing is sufficiently done, release the screwdriver. When the screw is completely released, the abutment will also be released together. The abutment ends up like this. The temporary cylinder will be released attached like this. Then, instead of removing the rubber dam right at this point, perform curing once more on the inner surface. Typically, this light doesn't penetrate all the way in. Normally, the surface is not so clean when you take a look at it. If necessary, cure the upper part as well before moving on. After removing the rubber dam, as you can see here, it has many voids, even more so if the case involves getting deeper inside. In addition, since this case is not for oral status, I have somewhat widened at my disposal. Then, it will go down that much more. There must be voids as well. Then, take those parts out and cure them from the outside this time. But if you do this without any measures, it may flow inside. So don't do it like this. This is where we use the holder and lab analog that I mentioned earlier. You wouldn't need many holders. If you have 2 or 3, you can use them one by one alternately. Of course, it doesn't matter if you have as many holders as lab analogs. Place the holder inside and see if it is the right size. As I said, with short and thin ones, you will have some gaps in the middle and you will never be able to remove the screw. So put something in with the size that fits. With the lab analog inserted at the bottom, lock it slowly and hold the lab analog firmly to lock the holder. If it is cured enough, it won't spin. You can do the same on the other side and lock tightly. Let's start with the base. Now, with the lab analog inserted, the resin will never flow inside. If you see any voids, fill them in. Since the work we are doing here are done outside the mouth, it will not be too much to deal with. Don't worry about the excess part. You can trim it out later. First, cure the inner surface first. When you are done with the inner surface, move on to the outer surface. There shouldn't be a big problem because the size fits. You can think of it as filling all voids, evening it out to the overall height. You can make it slightly low and raise it. Or you can do it later when filling the resin. If curing is done in this way now, you can bring several curing lights to perform the entire curing once. Because we are going to release the holder now, we should release when it is completely solid to prevent the temporary cylinder inside from spinning. When the work is done, check if there is any void. Again, this does not mean turning the holder on the top first. Hold the lab analog at the bottom and turn it together to release. Now, you have the whole thing inside the inner surface as well. It's inside the outer surface as well. Now it's time to trim it. You should trim the excess part a little. When doing so, you can insert the lab analog like this again. If it is not too much, you can trim it little by little with a burr. When trimming, you can remove the wing like this. Because the temporary cylinder is already in its position anyway, and this prosthesis will fit well.
그걸 다 했다라고 친다면
If you've done it, it'll fit just like this.
말씀드렸던 것처럼 엑스레이를 한번 나중에 저기
As I said, you can use the panorama or standard X-ray later to check whether it is fully tightened before setting it like this.
세팅하시면 됩니다. 일단 트리밍은 제가
I will do a brief job on trimming.
자, 대략적으로 이렇게
I roughly trimmed it like this.
여건이 안 좋기 때문에
Please take into consideration that I wasn't able to make it pretty due to the unfavorable circumstances. I don't need the wing now, so I'm going to remove it.
그리고 다시 구강 내
And assuming that everything is fastened inside the mouth, you can insert it like this and then insert the screwdriver.
넣으시면 됩니다. 자, 제대로 된 걸
If you use the right one, the screwdriver will be inserted all the way.
여기서 아까 말씀드렸던 것처럼
As I said earlier, you can tighten it at 20 Newton.
조아주시면 됩니다. 만약에 여기서 스크루가 걸린다면
If the screw gets stuck here, tighten it a little more.
크게 문제 안 될 것 같습니다.
It wouldn't be a big problem.
만약에 엑스레이 상에서
If you see that one of them is less inserted or is not fastened on the X-ray, I recommend excavating the resin and starting over.
최종 보철이 아마 안
Probably, the final prosthesis will not fit.
다 다듬어진 게
If this is the trimmed one, a total of 6 abutments will have been fastened like this.
어버트먼트가 체결이 될 겁니다. 나머지들도 똑같은
The same procedure will be used for the rest as well.
실제로
When actually inserting the prosthesis to the mouth, it will be inserted like this.
잠깐만요. 한번 끊을게요. 자, 구강 내 하악과 완전 체결된 이
The immediate prosthesis fully fastened with the mandible in the mouth is fastened like this, as you saw in the photo earlier.
체결이 됩니다. 그 상태에서 바이트를
You can look at the bite in that
한번 더
state.
확인하시면 됩니다.
You can check it once more.
조절할 게 많지
There won't be much to adjust.
구강에서 만약에 구강 내에서 이런
Assuming that this has been done in the intraoral status, I'll show you scanning once more.
보여드리겠습니다. 스캔하실 때는 말씀드렸던
As I mentioned when scanning, I will take out the maxilla to scan because I will have to scan both the inner and outer surfaces.
작은 구강 내에 있는 그
The mandible will be scanned in the mouth.
말씀드렸던 것처럼 이 RPD는
Of course, as I mentioned, you don't have to worry about this RPD.
자연치가 있다면 자연치고 그대로
If you have natural teeth, you can scan them as they are. Today, I will only cover what to do when scanning trios. I will show you the scanning process of the full arch system.
구강 내에 있는
First, release the immediate prosthetics in the mouth.
스크루는 있어도 되고 없어도
It doesn't matter if the screws are there, but since the screws may come off while scanning, I recommend removing them in advance.
이 구강을 촬영하는
It's not the mouth that's being scanned.
보철을 촬영하는
It's the prosthesis that's being scanned.
상악을 스캔할 거기 때문에
I'm going to scan the maxilla, so I'm going to scan like this.
촬영을 잡아놓고요. 먼저 촬영을 해보겠습니다.
Let's first scan.
촬영하시면서 방금 전처럼
Sometimes the scanning skips like before.
랜드마크가 없어서
That's because of absence of landmarks.
When you scan, you can't scan all the buccal surface and separately scan the lingual surface.
You should go back and forth like this to scan to make the buccal and lingual a one side. There will be no borders.
생각보다 이렇게 내외면 스캔했을 때
You will see that scanning the inner and outer surfaces is more difficult than you think.
어느 정도 촬영이 됐다 그러면 여기서
If scanning is done to some extent, do not scan until the end.
흑백 전환을 시켜서 촬영이 된
Switch to black and white to check whether the scans were made.
부분은 저희가 지금 한
Anyway,
게 아니기
this part will
때문에
not be scanned because it's not the part that we have just worked on.
촬영이 안돼 있는
These parts have not been scanned as of now.
중심으로 해가지고 그쪽
You have to take more pictures of the part that has not been scanned.
매직을 그렸다면 좀 더 좋을 수 있을
These are some situations that make you feel that it would have been better if you had a marker pen to draw.
넓은 면을 촬영하다 보면
When scanning a wide surface, you may not be able to recognize which surface it is.
랜드마크가 될 수 있게 매직을 그린다.
So it's better to draw with a marker pen to show a landmark.
그렸던 것처럼 가장 중요한 건
As I said, the most important thing is the inner surface area of this cylinder.
완전히 깨끗하게 나와야지.
The inner surface should come out completely clear. There is no need to block the hole over there.
자, 지금 보시면 어느 면으로 돌려도
If you see here, even if you turn it on the outer surface, this inner surface comes out completely,
촬영이 됐다는 전제에
with the premise that the other side has also been scanned.
자, 여기 보시면 전체적으로
You can see the entire scanned surface is clear and in place. This sets the stage for work.
이 덴처의
The bite can be captured with the occlusal bite on this denture.
그다음에 대합시 하악을
Next, you can scan the antagonist mandible.
지식은 크게 지금은
The dental formula isn't important right now.
전체 면을 다 깨끗하게 촬영했다는 전제.
Assuming that every surface has been scanned clearly,
대합치 스캔을 하시면 되죠. 여기는 빨리 넘.
you can scan the antagonist. I'll move on to the next one quickly.
자, 하악 촬영하실 때 중요한 건 보도 쪽이
In scanning the mandible, it's not important how much of the border comes out.
잘 나오면 되고요.
It's the occlusal surface that matters.
나중에 바이트 시켰을
Scans of the
때
points that would serve as landmarks when having the bite face towards the buccal later matter.
불필요한 부분들은
Delete unnecessary parts.
자, 하악이 스캔 됐고요. 바이트 스캔할 때는
The mandible was
구강을
scanned.
다시 체결을 해야
When
돼요.
performing a bite scan, it needs to be fastened in the mouth.
스크류로
It's done in the same way as before.
자, 이렇게 해서 6개를 다 체결했다고 가정하고
Let's say that we connected all 6 with screws like this and proceed.
크게 나쁘지 않았을 거고요.
If you check the bite, you will see that it is not too bad.
어느 정도 물린
Since I have no way of checking the bite right now,
진행을 해보겠습니다.
let's proceed assuming that has a good bite to some extent.
가정하고 그 바이트라고
Let's assume that it has a good bite like this and move on.
그냥 다물게 하시고요. 그 상태에서 덴처와
Just let it close.
대합치가
In that state, scan to see if the denture and the antagonist meet.
통상적으로 저는 바이트 1, 2를 다 써서 바이트
I usually recommend using both bites 1 and 2 for the bite.
자, 1, 2 바이트가 괜찮게 물어졌는지 전체적으로 확인을 하시고
Check whether 1 and 2 bites
이렇게
have
하면
come out
스캔이 다
nicely.
끝난 겁니다. 그리고 만약에
This way,
베이스를
the scan is over.
저기 치은 부분이 많이 퇴축이 됐을 경우
And in case much of the gingival part has retracted,
촬영하기 전에 밑에
place a light body in advance underneath and scan it like this before scanning the base.
스캔하셔도 됩니다. 그렇게 해서 프라치 시스템에서 스캔은 다 끝난 거고요.
This way, the scan of the full arch system is done.
지금의 바이트를 기준으로 해서
The remaining work involves sight for work.
작업이라고 생각하시면
That will provide a basis for a metal frame on top of which these prostheses will be placed.
올라갈 것입니다.
This is how scanning is performed. Thank you.